Hello and welcome to the Center for Medical Justice. I'm Dr. Joseph Parker, and today we're going to be talking with Katie Larson. Katie, how are you doing today?
As well as can be expected.
Tell us a little bit about who you are and what your experience has been.
Um, so I know that you are primarily these days you've been dealing with the field of pain management. So I thought we would kind of just start from the beginning and take it on up through the career and patient experiences and all of that. So I was a premature baby, actually. I was born in 1984, and I was um, about eight-ish weeks early, which isn't as big a deal now, but 40 years ago, that was a big deal. And I noticed it was really interesting. You graduated from Mayo Clinic, um,
Yes.
which is attached to the University of Minnesota Medical School, which I have had familial and professional ties to for my entire life. So I don't know if you've heard the term, the word, I'm sorry, the name Dr. Ted Thompson or Theodore Thompson. He was a
Oh,
kind
that
of
does ring a bell.
neonatologist. Yeah, he was my neonatologist when I was born, my consulting neonatologist at the university. And my mother ended up working in student affairs at the University of Minnesota Medical School, specifically running the committee for student on student scholastic standing. And Dr. Thompson was on that committee, and so I knew him my whole life, pretty much. He watched me grow up, and I knew him until he retired and passed away. And now he's actually his final resting place is right next to one of my family members.
Oh, that's
So
amazing.
weird. Yeah, and my grandmother, I was very close to both my grandmothers. They were very, very strong and powerful women in their own rights. And my grandmother was the oldest living kidney recipient in the country at the
Oh,
time when
wow.
she passed. Yeah, she was part of the original clinical trial with Dr. Nigerian. So she was followed by the university her whole life, obviously. So yeah, I mean, it's it's like we're all, it's a big world, but it's a very small world, right?
It is indeed. Yes, ma'am.
So yeah, I was very happy to hear you're from my neck of the woods, so you understand a lot of what I'm going to talk about. Um,
Yes.
but I actually, so if you can see I don't know if you can see very well on the screen, but I have kind of a scar right in here. I point with my middle finger, of course, right there. I have a history of trauma to my head, and my first one was at age 4. One of my cousins pushed me down the stairs on Christmas Eve. And I kind of like if you can picture the door jam and my head just went
Oh,
um and I was a very stubborn child, first of all. My first word I ever spoke was no, and my second word was bye-bye. So all the adults in my life knew I was kind of going to be trouble. But I ended up having to go have stitches, and it took 4 grown men to hold me down
oh, wow.
because I was so scared of needles and they needed to give me the lidocaine and everything. And yeah, so they eventually strapped me down in like a little papoose. And I do remember this all happening, but I will say I made out like a bandit at Christmas that year. Everybody went shopping. So um so that was the first one. And then when I was 10 years old, I was tumbling in gym class. And I remember telling my gym teacher, Mrs. Engel was her name. And I said, it sounds like a bag of chips crunched in my back.
Oh,
And she brought me to the school nurse. The school nurse, and this is very interesting, this was the first time I was gaslit by a provider. Um, I remember she did that thing where you do the soft voice like that, and she goes, "Well, you don't have any medical training. There's nothing wrong with her." And just totally dismissed it. And she said, "No, I've seen this injury before." And she called my mother. She went over her head. She called my mother. My mother took me to the doctor and then to a chiropractor. So I started getting pain management and chiropractic care when I was 10. And when I say pain management, I'm not referring to opioids. I'm referring to other things, obviously. Um, and then when I was 15, I was in a fatal house fire. So
oh,
my aunt and her dog passed away. I survived because I was sleeping in the basement. There was a bedroom downstairs. And I had to go up and down the stairs 3 different times to try and work on a side door to get it open, because the fire had progressed to the point where I just literally
oh,
couldn't even see the hands in front of my face.
right.
And between the second and final time, I fell down the stairs. I hit my head. I struck it on, I don't actually remember what I struck it on. I just remember feeling the on my head. And
Right.
then all of a sudden I came to again, and the room around me was a lot darker, the air, atmospheric air. So it was a lot darker brown at that point. So I knew that I had lost consciousness. I just don't know how long
Right.
exactly. And the interesting thing about that, when I think about head trauma, concussion care, and things like that, the way we do it now versus the way it was in 1999. The fire was December 22nd of 1999, the day that will live in infamy, at least for me. And it just night and day. I now know, knowing what I know and having felt what I felt and having had the patient care experience that I've had now, I know that I had an anoxic brain injury. Um, I can remember having really horrible headaches, dizziness all the time, seeing things. I couldn't walk, and they basically treated it almost like I was psychosomatic.
Oh,
They were trying to write it off as trauma related or something. And I actually couldn't go home because we lived on the third floor of an apartment building and there was no elevator. So I had to stay at another aunt's house because they had a first floor bedroom. So I was there for a few days before I was able to go home. But yeah, having had further head injury, I know what it feels like, and that's exactly what it was. And I do have uh, some upset and maybe even some resentment for not being worked up more thoroughly in that respect. But I did have to get, obviously, my back, my neck, my body, my whole body hurt. And that was actually the first time I ever had an opioid. I was given a small dose of morphine in the ER when I went in.
okay.
But other than that, they were like, take ibuprofen and have a nice day. And
Right.
there wasn't really any, take her to her pediatrician, I guess. And I did go through respiratory therapy. I did have, as preemie babies have, we now know it's RSV, and we know what long RSV looks like in children and pediatric patients.
Right.
Um, and we give the injections before preemie babies are born now, the steroid injections to, increase the surfactant in the lungs. I didn't have that.
All
So
right. Right.
basically, I had a lot of respiratory infections and chronic health issues and things like that. And I didn't present like a normal patient because, when you're born prematurely, you're kind of a few steps behind. So you're just not always going to present like the typical patient. And so for my whole life, it's always been, well, this is a little unusual.
I see.
I'm used to it. I've heard it from my doctors. And then at 19, I was in a head-on collision leaving college, driving to wherever I was going. I don't remember exactly, but a guy driving a red pickup truck with no insurance plowed through a light and came in and, hit my car, the front of my car. And then I was thrown to the side. So I hit this side of my head. And then I remember telling the ER doctor that it feels like my head's going to pop. I was grabbing it like this and I was like, it's going to pop.
Hmm.
Make it stop. Please just make it stop. I can't take this, begging.
Sure.
And I remember the medication I was given. I was given a shot of Demerol with Vistrol, which was a common combination they used to use back then.
That's right. That's right.
Yeah, for acute severe pain, which I was definitely in. And I did several months of physical therapy after that. Um, and then, of course, I had started out doing patient care when I was a teenager. I used to go and do community visits with our parish nurse. And that's how I knew that I wanted to somehow be in a helpful or some sort of helping profession. I knew that that's what I wanted. And originally, I had intended on going to nursing school, but the waiting period was so long to get in at that point. Now it seems like you just can't pay people enough to get into the field, but back then, there were waiting lists years long, and so I ended up getting a degree in social work with a minor in what was called pre-health sciences. So all of the sciences that you would do like before medical school or before.
Oh, excellent. Excellent.
Yeah, so I did that. And I started out professionally when I was in college. I worked as a nursing assistant and then as an MA in long-term care. And I guess that's when I started to really see some of the issues with pain management in patients professionally was during those experiences. Um, and now we're kind of in, that 2003 to 2006 era, which I know we talked about that before. Um, the first thing that happened when we started phasing out opioid therapy was they came for the elderly first.
Right.
And first it was, psychotropic medication. The Centers for Medicare, forgive me if I'm saying the agency name incorrectly, but they came and said, we have to start taking anyone over 65 off mental health medications. We have to titrate them down. You have to keep titrating them down. And I remember, we had documentation classes on what we were supposed to be writing in our attempts to not use any type of pharmacological intervention. And you would have these patients that would just be suffering a lot. They'd be up all night screaming, kicking the walls, not able to sleep. They'd be awake for days at a time.
Oh,
And,
wow.
you'd give them, some of them, you'd give them like 0.5 mg of Ativan and they'd sleep all night. I remember this
Right.
one woman, she just, for 2 months, she'd been in this cycle. And in that case, it was the daughter that was very resistive. But eventually, we were able to give her, and I remember it was 0.5 mg of Ativan, and she was out all night long. And she woke up, and I went in and I said, "Well, good morning," as I was going to leave. And she goes, "Hello, dear. Have we met before?"
Yeah, that
Yeah, but that's okay.
you would think if someone had been on a medication for decades, it might not be best just to
Mhm.
across the board taper everyone off because a subset of the population has some sort of bad reaction or something.
Right. Or I'm thinking of another woman who was a paranoid schizophrenic and had been on mood stabilizers since the 1960s and was going into these acute manic and full-on psychosis episodes as a result of being force titrated off those medications. And it's like, that's not beneficial. And then moving into moving into the discussion of pain management, I watched my first patient force tapered off opioids in 2006. And I remember this very well. There was no explanation. That was the interesting thing. I remember looking through her chart, like, why is she being tapered down? She was on, we used to call it Vicodin back then.
Mhm.
And, she'd be on her what was it, every 6 hours, her 2 tablets every 6 hours, which was very standard.
Right.
Um, or we would do things like, they would be on a fentanyl patch of various doses and they would have something ordered for breakthrough pain. That was another very common intervention for these long-term care patients. And I mean, and it was very effective. They did well. And obviously they didn't have access to the medication, right? They were monitored.
Right, right. No one's going to overdose on regular
No,
medications taken at regular times.
absolutely not. And, really it was a quality of life issue. I mean, you would see some of these people and I mean, literally I remember you could just hear their bones just creaking when they'd walk
Oh,
because they'd
wow.
have, some of them would just have bone on bone all over their
Mhm.
body and they would just be crying just to walk to the bathroom. I mean, we're
Right.
talking serious pain here. And this woman, I remember this woman looking up at me and she's like, "But I'm hurting. I'm hurting." And of course, I'm the one that's got to say, "I'm so sorry. I can't. It's got to be at this time." Why did they take them away? I don't know because I didn't know. And I
Right,
remember having several conversations and I was like, just all of a sudden she's just on less medication. And there really didn't seem to be a reason. And now I know that that's a forced taper.
right.
So for some reason, whatever physician was in charge of her was told to do it, or something happened. I don't exactly. I never got an answer.
They
But I
usually
remember.
set institutional guidelines where they say,
Okay.
we will not continue past 30 days or, we need to taper anyone over the age of whatever. And, of course, those somewhat arbitrary guidelines, they don't take into account the individual patient's situation, which of course is always bad medicine.
Yeah. And I remember this woman's roommate. She'd always grab as I was walking by, she'd grab my scrub top and she'd go, "Can you please help her? Help her, please.
Mm.
Can you give her?" I remember at one point she said, "Can you give her some of my pills?"
No,
I said,
that's,
"No, I can't do that, honey. I'm sorry." And
yeah,
it's like, and I remember calling, we called the on-call doctor a couple of times and he said, "I can't, I'm not gonna alter, this plan of care at this point. There's nothing, there's no injury, there's no there's no acute reason to do it." And I just, oh my gosh. And then you had talked about something interesting about how in the early 90s, there was a trend where you had oncology patients that were just screaming in pain while they were dying, and there was some interventions to address that. There's another patient I'm thinking of, but I'm interested in hearing a little bit more about that.
I've seen the entire paradigm shift. So when I started studying medicine in 1993,
Mhm.
patients were still pretty much left in agony, even if they were dying, because the doctor would say, I don't want you to get addicted. Because at that time, the DEA had gone through in the 70s through 80s and up into the 90s. If it could be argued that a patient had addiction, they would try to arrest you or take your prescribing privileges. And the law actually reads that it's illegal to prescribe an opiate for the purpose of maintaining addiction, not for the
Okay.
purpose of treating pain in someone with addiction. And all of the medical organizations say, of course, you can treat pain in someone with addiction. The DEA absolutely says, no, you cannot. And the judges, they think that's the law also. They
Really?
haven't read the Controlled Substances Act closely enough, or because they're judges, they get to interpret it any way they want to. But basically, they say, oh, well, a judge said to a doctor at trial, said to the jury, you cannot find the doctor guilty unless you find he committed a clearly illegal act like prescribing pain medications to someone with addiction. And I'm like, oh, there you go. Because all you have to do is pay someone to retroactively diagnose a patient with addiction. And now
Right.
that they've changed the DSM-5, and this really started when they changed the DSM-5. When they
Right.
changed, well, the DSM-4R or whatever it was, the DSM-5. When they
Right.
changed it to where there's no longer addiction, now it's all a spectrum of substance use disorder. If you have
Mhm.
social impairment and
Mhm.
reduced toleration of activities, you've got mild substance use disorder. But not really, only if it's related to a drug you're taking, not if it's related to your baseline pain. But all of
Right.
those criteria can be applied to pain patients because pain takes all that away from you. Your mood changes, all those things. So every pain patient can be wrongfully diagnosed with a substance use disorder. Because do you want more medicine? Well, yeah, I'd like to hurt. I'd like not to hurt so much. Oh, okay. Have you tried to quit? Well, of course, my doctor told me to try, and I tried, but it wasn't tolerable. Okay, well, now you've got substance use disorder. No, you don't. None of those criteria should apply to someone with severe chronic pain, but they do. And so doctors were terrified. And so no one would treat anyone with anything. And then the paradigm shift came. They were saying, you're
Mhm.
all being cruel. You need to treat pain. Pain is the fifth vital sign. So everyone
Yep.
started treating pain, and it can be argued that doctors got a little bit lax, but they self-corrected. By 2010, the prescription rate had leveled off. By 2012, it had dropped a little bit.
Mhm.
Everything was self-correcting. But never underestimate a federal government's ability to take something that's slowly improving and make it dramatically worse really fast. So that's
No
when,
matter what it is.
yeah, they switched the other, they switched it to the reverse, and all of a sudden, I had been called in front of the medical board once before for stopping someone's pain medicine. Why did you stop his pain medicine, doctor? You're a bad doctor. Well, he tested positive twice for meth. Well, okay, we'll let you go this time. Now you test positive for meth once, and they say you absolutely must cut off that patient's pain medication, even if you believe it will kill them.
You
Because
know, I have an interesting thought, if I could piggyback off what you're
please,
saying. Why is it then? I mean, how are they, if this is the thought process in these macro level oversight systems that you're talking about, then what do they think about methadone programs?
they think methadone is a controlled addiction. Suboxone is trading one addiction for another. Realistically, when you look at law enforcement and the majority of medical providers who don't treat chronic pain or addiction, or at least don't treat both, realistically, if you don't have experience with both, you don't have a balanced viewpoint.
Yes.
There was an addiction specialist in Massachusetts who was trying to get a law passed that said that the first doctor to write someone an opiate was responsible for any substance use disorder ever developed in that person's life, would have to pay for the first 90 days of inpatient treatment. So you could write
So the
size
doctor that gives me a shot of morphine because
exactly
I've just
you
been through a fatal house fire and I'm covered in
exactly.
soot and burns and
He would have been responsible if you had developed a heroin addiction 20, 25 years later, probably self-medicating from the trauma of what you'd been through, then the doctor's on the hook. Well, that's because the addiction specialists, they tend to see all addictive substances as just toxic and you should never touch them because they're afraid of them, right? That's what they see.
right.
Just
Yes.
like oncologists usually don't smoke. It's pretty rare to find one that smokes because they're aware of the
ER
risk.
docs, on the other hand.
They do sometimes. because they're high risk, right? They're the ones that ride the motorcycles with no helmet.
Or
Those were
the
my colleagues. I was like, why?
endless
Why, Fred?
caffeine.
Yep. And it's the pain specialists are sometimes they say the pain must be treated, or the patient's at a higher risk of death. And addiction is a known complication, just like an infection with surgery. If it happens, we'll treat it, right? And they try to practice that way. But the federal government now wants you to eliminate all risk of addiction, all risk.
It's impossible.
It's impossible if you're prescribing. The only way to possibly eliminate all risk of addiction from your medication is to not prescribe. Now, you're putting the patient at a huge risk of addiction and death because they'll go to the street and find something, because people don't want to be in agony, shockingly. And people don't tolerate pain well. Now, there's a good book by a CDC scientist called Greed to Do Good. The CDC scientist was one of the ones that helped develop the guidelines and protocols. And he talks about how they were in their ivory tower, and they were, the law enforcement was telling them, hey, we need a speed limit, and we need the doctors need guidance. So they came up with these opinion-based guidelines and propagated them. And then he saw how it was being enforced as if it was holy writ, some type of evidence-based mandate, when it was not at all. And then he developed a severe pain from, I think he had spinal meningitis or arachnoiditis. He had
Oh,
something that just about made him want to die. And
yeah.
that's why he wrote his book. He said, we had no clue. We sit up there and blithely talk about chronic pain as if it's, the toothache you once had or the broken bone you once had. But he said, it's like having your spine set on fire continually for months at a time, where you're actually wishing you don't want to commit suicide, but you're just hoping you'll die to get it over with. And he
Yep.
was actually at that stage, and he wrote a wonderful book about it. And
I understand. I've been there myself. I understand what it feels like.
it is
Not want to
something
die, but
that,
to not know how you're going to live with that kind of agony.
and people with empathy can understand and try to put themselves in that place without knowing. We can try to understand. People without empathy, and I hate to say it, but that's a lot of prosecutors and law enforcement officers. They just don't understand. They can't put themselves in that other person's shoe, and they just think you're weak. It's a moral failing. You should just be tough, suck it up. And
Rub
now,
some dirt in it and walk it off, son.
absolutely. And now we've got pain review boards and medical boards
Mhm.
telling people, well, you know what? I'm going to cut you off your pain medicine. If you shoot yourself, that's on you. That's not my fault.
Well, it's very interesting that you say that. I know we were going to kind of go step by step, but fast forwarding a little bit in my life, back into my paramedicine career. I had a medical director who's now retired. His name is Dr. Keith Wesley, and he was the medical director for what was then called Health East Care System. Now it seems like every care system's buying out every care system, and it's like eventually the financial people that are buying up all these care systems are going to eventually just buy us into universal health care. That's what I think is going to happen,
Yeah.
eventually. But he actually did something called pain report cards for all of his medics. And as an ER doc, I know you understand, that the physician-medic relationship is quite a bit different than the physician-nurse relationship. I mean, similar but different. And what he would do is he reviewed all of our narratives. And he would sit there and just click through patient charts. And it wasn't actually meant to criticize our analgesia choices. It was actually to make sure that we were using appropriate pain management choices. And his philosophy, which I have taken very much to heart, it's very similar to what mine has always been, was it's not our concern if the patient is an addict. It isn't for us to worry about. We are not the long-term care provider.
Right.
What happened to the patient? Does the patient have a need for pain control? And pain control does not necessarily mean narcotic pain control, right? We have other medications. We have ice pack. We have positioning. They actually put, this is kind of funny, but they actually put essential oils kits in the ambulances, and we were supposed to give them.
Yeah,
We were supposed to give them hand massages.
I thought that was all bunk, and I read up on it, and I'm like, well, okay, it does.
Yeah.
Lots of things happen a little bit. Believe it or not, if you reach the guy a $100 bill, it would ease their pain for a little bit. They would get a boost of endorphin, and it would ease their pain better than the essential oils for a brief period of time. You know, you got to keep
Yeah,
handing out
something to
hundreds.
focus on.
That gets expensive.
Yeah.
But yeah, a lot of things will ease pain briefly. And I think that's a problem with a lot of the studies they're doing. They say, well, we did a study with acute surgical pain and a good massage helped. And so no one needs long-term pain treatment. They just need a good massage. I'm like, are they going to get a continuous massage? Because they're in continuous pain.
Right.
So unless the massage is going to be 24 hours a day, 365 a year, you're not addressing the problem. Even then, that's going to get annoying, right? So
Exactly. I mean, and I call that the multifaceted approach. That's how I look at it, is that there's always many different aspects. It's not just opioid therapy. And in fact, I had many patients that, were in recovery that would say, I don't want any narcotics.
sure,
And
sure. I had a gentleman come in, a pecan picker had chopped off his leg right below the knee, had just like a pencil. And I was getting everything. They're getting the IVs hooked up and everything. I'm okay. Do you have any medical history? He said, I'm not allergic to anything. I'm not on any medicines. I said, have you ever had any problems with pain medicines? He said, yeah, I had a problem with, with heroin at one point. And I said, look, this is a really bad injury. I can give you Toradol, but it can thin your blood a little bit and make you more likely to bleed. You're not bleeding right now. It's because the muscles are clamped down, but there's a good risk that you could, really start bleeding. I said,
and that adrenaline dump you got is going to wear off and you're going to really feel.
exactly. And I said, do you want that? Or do you want morphine? Do you want me to try something in the middle like Nubain or Stadol? He went with
Right.
Stadol. He said, I said, well, it's a partial opioid agonist. It won't be as
Right.
strong as the morphine. He said, okay, do that one. And it worked. It worked. It was obviously he was a very, he was tolerating a lot of pain at that time. And then we got him.
Probably a very stoic individual.
Yes, yes, yes. He called his mother and apologized. He said, I'm sorry, I won't be able to work for a while. I'm like, you just had your leg cut off and you're apologizing.
Oh my gosh.
I
Almost like in Minnesota, in southern Minnesota, we see the stoic Scandinavian farmers, man.
yes.
I've
I saw
I've
one.
had them watch. If the wife didn't make them come,
That's right.
it's a problem.
I
Get
saw
the
one at the Mayo emergency room. I was doing my ER rotation for medical school, and he comes in, he's got his hand wrapped up. And so he waits his turn, and we're like, oh, what's going on? He unwraps it, and of course, it's just mangled horribly. We're like, what? And he's like, yeah,
He drove himself, right?
got caught in a farm tool, but it just wouldn't stop bleeding. I'm like, oh, son of a gun. But yeah, no, they can be very, very tough. But tolerating something, I have experienced pain. I've had injuries. I'm
Mhm.
lucky I have a high pain tolerance. I have a high endorphin release, so high that when I hurt myself, I sometimes get giddy, which
Oh, really?
doesn't work well for me. I had a motorcycle wreck. I'm laying there under the motorcycle. I'm giggling. Someone came running over to help. They heard me giggling. They ran away. I'm like, no, no, no. I'm not giggling because I don't need help. I'm giggling because it really is that strong of an
Oh,
endorphin release. But then it
yep.
wears off, and then you're really miserable.
And then you really feeling it. Yep.
Yes.
Same way. Now, so when I hurt myself, I've always been very klutzy. I actually had a reputation where um, I would always fall and hurt myself somehow, and I would need medical attention. And so it's like, did Katie make it through the winter without having her fall yet? And it got to the point where one of the everybody knew about it, and I was in Dakota County. I was north, in kind of like the north of southern Minnesota, and the fire chief was there, and a couple other people were there, and they go, oh, be careful when you get out, it's glare ice. And I could see them kind of slipping around even in their gear and their boots. And I went, oh, I haven't had my fall yet this winter. And they both just grabbed onto either side of my arm, one on one on the other. And they're like, and you ain't doing it today. And I'm like, nah, because I know how you package patients. And we're just kind of spitting game as they're like sliding me along into the patient's house. So
Tell you
I mean,
something interesting. My experience with pain patients is
mhm.
not that they cannot tolerate pain well. It's
Yeah,
that they tolerate levels of pain that most of us would end ourselves with.
right. And you see the Braden scale, the what's your pain 1 through 10. There needs to be another one for chronic pain and chronic illness patients, because our baseline and what we might call a 0 or a 1 would probably be somebody else in the hospital.
Exactly. A good day would probably make me cry. I have had patients who are in such pain that when they come in a good mood, if I felt that level of pain, I'd probably just fall on the floor and kick like a little kid.
Even
And
now, as we're sitting here, I can tell you, I have SI joint dysfunction. We haven't gotten into my injuries yet, but I have SI joint dysfunction. So right now it feels like there's a stabbing pain coming out of my rectum and my lower back's on fire. But I'm just sitting here chatting because you know what?
you got to get by,
Today.
you got to get by. And the sad
Yep.
thing is that when you go see the doctor, if you smile too much, you're not in pain, you don't need medicine. If you cry too much, you're being manipulative and you don't need medicine. And if you're dressed well, then obviously you don't need medicine. If you're dressed poorly, then obviously you have depression and you don't need medicine.
Yeah.
If you've ever
Or
had a
you're
trauma in your life and you're a woman, you don't
Mhm.
need medicine. If you're a man, you're just amazingly immune to trauma of any kind.
You know,
So you can go ahead and have it.
what you say about that is interesting. So, I did want to mention, there has been a lot of peer-reviewed research that's been published that does prove that a woman's pain is taken less seriously. So women only get appropriate
Absolutely.
analgesia about 50% of the time. And if you add in, there was a study done out in Colorado, actually, if you add in being of color or LGBT status, that drops to about 25%.
You
The data
you
is
will
out.
die. You will die telling the surgeon, I'm having terrible abdominal pain. An African American woman did die. She was telling the doctor after a surgery, I'm having terrible abdominal pain. He said, it's, it'll be okay. They didn't want to give her pain medicine. She just wants pain medicine. He didn't examine her, didn't test. She was bleeding internally. She died.
Yep.
The weird
I've
thing
seen that
is
actually happen many times personally.
the studies show women have a higher pain tolerance than men. So when a
Mhm.
woman says something hurts, the man would usually be crying at that point. Women can tolerate pain that would kill men. We know that intellectually. Studies have
Mhm.
also shown that African American patients benefit from opiate pain relief at a better rate than Caucasian patients.
Yes.
Overall, there's something with the genetics, the enzymes, the receptors, they
Mhm.
benefit more, but they get it much less. And to a degree, this is forced upon us. So I treated 29 people over a 2-year period for chronic cough. Half those patients were men, half were black, half were white.
Okay.
So that makes about 14, right? 15. Of those, about half were men, half were women. Of
Mhm.
those, about half were young, half were old. I got prosecuted for every young black man I prescribed to because that community has a high risk of diversion. And one of the reviewers was kind enough to write in the margin, prescribe codeine cough medicine to black men, and he capitalized all the black. And I'm like, I was totally unaware that there was some study out there that said I could not treat all my patients equally when they happen to be black. Their thought was
Systemic racism in healthcare.
it's popular in the rap community, therefore all black men must be rap fans and must be out there abusing it. And so that's a high risk diversion community. What they're really saying, this is institutionalized racism.
Hmm.
You
Well,
must
for
assume that they're misusing it.
for those who don't know, they're talking about grape drink, which
Yeah,
is
drank, lean,
sodium
all that.
crop-
My
yeah.
kids educated me. I'm like, kids, what the heck is this? When they charge me with it, what the heck? Who wants to drink cough syrup? We've been using it for 30 years. Nobody likes that. They're like, oh yeah, that's
With juice and Red Bull. What do you want? What are you
and
doing?
they played the Lil Nas X video
Yep.
for me where the cowboy won, and
Yep.
he's lean, and I'm like, lean? What the? Anyway, Chat GPT educated me, and so now I know all about it. I'm an expert.
Yeah. Well, if you want to know, ask the medic. You want to know what's going on the street.
It's very true, very true. And when you
Um,
talk about nurses and medics, the difference is that you guys are extremely independent, and you basically call us to tell us what you're going to do, and we double check and make sure there's no contraindication and say go for it. Nurses are waiting for an order from the doctor. Now they know a lot, and there's a lot that they do on their own, and they work harder than doctors do, in my opinion. But they're
yes.
not going to independently assess and treat. You guys are right there on the scene. You've got to do things right then.
Yep. And
So
we do have our standard operating orders. We used to do the SOG books and now we all have apps on our phones. So,
it,
I still to this day have all the apps for all of the Minnesota ambulance services on my phone because we had to learn all of them and work under all of them and prove we knew them before we were allowed to graduate.
if I'm ever in a car wreck, I would rather have an EMT happen upon my car wreck than a doctor, unless he's a board certified emergency medicine doctor and he used to be an EMT. I want the EMT there because the doctors won't know as much about, they're all packaged up when we get them.
Mhm.
when you guys bring them to the ER, we're like, oh, he's in his neck brace. And, we'll remember the neck brace after we pulled you out of the car. Oh, I probably should have stabilized his neck before I did, you know what I
Or
mean?
you're,
We just,
or you're gonna be like, hey, backboards are going out of style. Yeah, well, I had to get him out somehow, so
yeah,
he got
it's,
boarded. Sorry.
yeah, it,
They
it,
still have a place.
it's a paradigm shift, and it's
Exactly.
absolutely needed.
Yep, trauma care, cardiac arrest management. You've seen the trends and the paradigm shifts throughout your career, just like we all have. But
Yes, yes.
anyway, if we want to take a trip back to 2006 for just a second, this patient that I had, absolutely the most beautiful pair of eyes I've ever seen in my life. They were violet. She had violet eyes, breast
Wow.
cancer, terminal breast
Mm.
cancer, but always put on her makeup, had a whole headscarf wardrobe. She did different little ties and wraps and she was just a wonderful, wonderful woman. Her and the other residents that were younger actually would sit outside and they'd sit outside and they'd smoke together and they'd say, we're having our union meeting. And they'd write down letters to the administrator about what they didn't like about their care. And I was like, good for you, good for you ladies. But anyway, she we always had this thing. I would bring her, and this is how I learned about oncology pain management, was actually from taking care of a lot of these people on a long-term basis. And I would always bring her meds, and she was on high doses of oxycodone typically, or OxyContin, and then eventually I think it was MS Contin they put her on. But whatever. And I would always bring them in to see her when David Letterman did his top five every night on the show. We
Right,
would sit
right.
and watch it together and we'd kind of, have our little chat. And I'd always give her meds and she'd be taking them and we'd watch it together. And one day she said to me, will you stay with me when I die? And
Oh,
I said, do you think you're gonna die? And she goes, well, I'm terminal. And I said, yes. I said, I don't think that's going to be anytime soon, but of course, my answer was, of course, would be honored. Hospice patients, I would always call them, my new babies, because it's a privilege to be there at the end of someone's life. The
sure.
same as it's a privilege to be there when they're born. Absolutely. That is a very sacred care relationship. I'm going to cry. But anyway, I, uh, I said, well, of course I will. And lo and behold, and this is how I learned, listen to your patient. When they say they're going to go, they know. And she said, yeah, I'm not sure, but it's going to happen. And I mean, she was just dead serious. And 2 weeks to the day, um,
Wow.
it was 10:30 at night, I remember. And she all of a sudden, she started decompensating, started declining. And it looked like she was transitioning to actively dying. And I remember it was 10:30 and I'd seen enough people pass at that point that I could kind of figure out when things were going to happen. And I was supposed to leave. And I had my coat on and I went to check on her. And her family had come in and I was like, it's going to be tonight. And so I punched out, took my coat off, and I went and I sat down. I set myself up at a table in the hallway and let her family kind of be with her. And at around somewhere between 10:30 and 11, she started screaming
Mm.
over and over. And she didn't pass till about 4:30 in the morning.
Oh my gosh.
And she had the usual hospice orders, the Roxanol, Ativan, the Tylenol, atropine, all that stuff. Um, And so every single time she would have meds, and I knew her orders well. And so we were short staffed that night and she wasn't going to get the care she needed. So I knew that it was my job to make sure that this was going to go as well as it could go. And I was begging the supervisor, the nursing supervisor, the charge to call hospice and get orders. Several times I begged and she goes, they're not going to change it. I said, just call, let me talk to them. I know her. Like I'll talk to her. I was like, I'll take the fall. If someone gets mad, you can blame it on me. It's
Right.
fine. I mean, she asked me. I know what she said. Um, and refused. So literally I just gave her everything I could, kept her comfortable, managing the temperature, the towels, the music, the lights, the everything we could possibly do. But she screamed until she passed.
Oh my.
And there was a float nurse that we had that worked at that facility who also worked for that hospice agency. And she and I had a few hours of just sobbing together. Um, and she's like, you did what you could. This is not your fault. It's not your fault. And I'm like, no, but I said I would take care of her and I couldn't. I didn't have the tools. And it was just, it was heartbreaking, you know. And her family, you know, said, thank you for your care. And I remember I was mostly doing my statistics homework to pass the time while I was waiting for the
Yeah.
next medication window. But it was just, it just floored me that somebody would be allowed to pass away. And I'm like, I wish there was a shot, there was something I could give you to just end this. You know, and that's why, you know,
Yeah.
when we talk about euthanasia with humans, you know, that's why I am in favor of it with terminal patients, is because of that story.
Well, even
But I
states
still,
that don't have euthanasia, like Arkansas, you
yeah,
can use medication sufficient to relieve the pain, even if it hastens death. So you could keep giving medicine until that person quits screaming.
mhm.
And if that also hastened them not breathing, no one is supposed to fault you, right? As long as your goal is to ease their suffering.
And
But
that's what,
that's all been turned
because
on
that's what
its head
happened.
now. Yeah, that's all
Yeah.
been turned on its head now.
It has, and you hear things like opioid-free palliative care, opioid-free hospice,
Yeah.
you know, risk of addiction in hospice. And it's like, well, you know what? I hear they have NA meetings in heaven. Okay.
Yeah,
There's no reason you should let somebody die in that kind of suffering and agony. And what these people don't understand, what I wish some of these law enforcement agents and prosecutors and judges would understand, one day that's going to be you. You're going to be in that bed
Mhm.
screaming, and you're going to get what you need.
And then they'll
And
say,
you're going to
but
go,
it's different. It's different because I have real pain. I had a sickle cell patient in Louisiana call me from an ER, and I said, what's going on? He said, they won't give me anything. I said, well, let me chat with the doctor and let him know what you're on. I said, well, he's normally got medications he can take with him. He usually stays close to home. He's traveling. And the guy very proudly said, well, we are an opioid-free ER. I said,
oh,
then
great.
why the hell did you accept a man with sickle cell crisis? Why don't you send him somewhere else? What are you going to do for him?
What did
Because
you expect to do?
at that time, oxygen fluids and morphine, that's all you can do for someone like that, right?
Yes.
They're in horrible agony. Their bones are being crushed microscopically. And,
And I've had patients like that look at me and they've said, how much do you have on your truck?
mhm.
And I'm like, and they identify themselves as sickle cell patients. And you know what? I don't question it. I've learned.
Well, they become so tolerant, and
Yes.
their bodies are ignoring these doses, and so you're not doing them any good until you reach a therapeutic level. And that's another thing the DEA doesn't understand. They think that everyone needs the same thing, and that if you're exceptionally skilled and you're treating the sickest patients, that your prescription should still be the same average as
Right.
the family doctor who's seeing the occasional sprained ankle. And you're saying, no, 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 no. We've got cancer patients. We've got sickle cell patients, which we did. We've got patients, we've got oncologists seeing us patients, neurosurgeons, spinal surgeons. We see the worst cases and we're willing to manage their primary care and their pain. That's why
Mhm.
everyone sends them to us. Otherwise, you got to go to 3 doctors, right? And
Right.
they do not understand that. They think that 90 morphine dose equivalence is a speed limit, an absolute speed limit. And I've heard
Right.
medical boards say the CDC's mandatory maximum is 90. I'm like, there is no mandatory anything in any CDC document. So you're adding that. It is a voluntary opinion-based guideline. And if that's how it had been left, it would have been fine. It's
Right.
perfectly fine to tell me your opinion, to show me a guideline. Where we get
Yes.
into a problem is when people with guns tell us that we must conform to that.
Right.
So,
That is the frightening thing. And interestingly enough, I don't know if you knew this, the Social Security Administration uses patients that need doses beyond 90 MMEs per day as a disability inclusion criteria. I don't know if you were aware of that,
I
but
did not.
they recognize that those patients have such pain that they are disabled, that it's disabling. And you know, it's interesting. MMEs was never a thing I knew of until I transitioned out of patient care. I'd
Yeah.
never heard it before, and I
No one had. No one had. It was not anything that doctors, it was invented to create this speed limit because realistically, it's completely invalid, right?
right
Because the
pharmacologically,
polymorphisms, yes,
yeah,
pharmacologically, the polymorphisms for the cytochrome P450 enzymes and for the receptors are so varied You never see the same patient twice. No two people that
Right.
sit down in front of you with pain have exactly the same method of processing, response,
Yes.
activity. So you give some people Tylenol number 3 and they say it doesn't work at all. And you're like, oh, drug seeking. No, they might be the 18% of the population that cannot process that from codeine to morphine.
Which is a significant part of the
A
patient population.
huge part of it because it's the morphine that actually does the work. Codeine does little or nothing. And in some African American populations, that's 40%.
Right.
40%. So you've got this double whammy where you can't treat black people for pain, yet they're the ones that the milder medication doesn't work that well for,
Mhm.
right? But they're drug seeking, and that's one of the things they prosecute you for. They say, well, didn't he ask for an increase in medication? And you gave it to him, didn't you? If I have a patient with diabetes and their blood sugar is staying above 300, they
You're
don't
gonna
have to
increase the
ask me
insulin.
for more insulin. I try to get it down to a reasonable level, you know? And I guess my bitterness is that doctors are being prosecuted not for what they knew and chose to do anyway, but for what they couldn't possibly know, for criminal histories that we don't have access to and that should not make a difference anyway. Should
Right.
not make a difference. So for Dr. Hinderleiter, they said, 23% of his patients had a criminal record. Well, I looked it up. I said the adult population in the state of Arkansas, about 28% on average, have a criminal record. So he weeded out 5%. Why are you prosecuting him for that? The media didn't care. The DEA didn't care. If you treat anyone with a prior criminal history, that is a strike against you. So
And that's
for,
interesting.
go ahead.
That is interesting that you say that. So when I graduated in 2008, 2007/2008, I started out in addiction treatment actually. So I was part of a grant funded position that was a pilot program that kept mothers and their young children, or babies and young children, together while they were going through treatment. And that was a pilot program. And now it's common. You see that in correctional facilities. Um, as well as in
Right.
inpatient treatment facilities. And I mean, so all of my moms were, a lot of them had a history of prostitution.
Mhm.
Um, the average age a girl gets into the life is 12. You're trafficked
Wow.
into prostitution at 12 or younger.
Wow.
Um, and it's usually yeah, and they have very significant trauma histories. They also have very significant health issues. They also have very significant pain issues. Um, and in fact, and there were times where those moms, like one of them, I remember opted to have her tubes tied. And she was given pain medication afterwards, and we did a management plan. So we know she's an addict, but she's going to have surgery and she needs pain control. So these are the circumstances in which we are going to have her take those things. And of course, those meds are locked up. They can't access them. They have to go to staff to get them. Um, and everything is very closely monitored. And that's exactly how that should be done. It's not, of course, there's a risk of relapse with that, but she's inpatient.
That's the problem that we
Monitor
have.
all of
If
that.
that patient later dies of an overdose, they want to go back. A doctor in New York is going to prison, I think for life, because a patient he had prescribed oxycodone to later died of a heroin and cocaine injection
How many
overdose.
years later, out of curiosity, do you know?
How long after?
Yeah,
It might have been in close proximity, but the
oh,
whole point is that it's supposed to be but for.
right.
If and even if the doctor's medication had done them in, patients choose to take themselves out of the equation with their medicine quite often.
Yes.
And but more often than that, it's fentanyl or xylazine laced. In this case, it was real heroin and cocaine, which of course, if you inject heroin and cocaine, the point is that the doctor is held responsible for what he can't possibly know the patient will do. And they say, well, you ignored red flags. They make it so that they can comb through 10,000 patient interactions, find one or two that went bad, and then prosecute you with that, which means it is not safe to prescribe any controlled medications in this country right now. They
And
can
that's where,
always prosecute you.
yes, absolutely. And that's kind of where I ended up getting to. You fast forward, while I was working at the facility I told you about, I actually had a significant back and neck injury. A patient fell on me.
Oh,
And I had another one where I was like grabbing one of the bars in the bathroom. I was doing some foot treatments and I grabbed one of the bars to like pull myself up, and it came loose, and it went,
Oh,
that little nerve that comes through the supraorbital foramina, whichever, I forgot the name of
right,
that one,
right.
but just smacked it right there, man.
Come on, it's the
Oh,
supraorbital nerve. That's the
hey,
supraorbital nerve coming through the
hey,
supraorbital frame.
gross anatomy was the summer of 2004. Okay, bear with me, doc.
I taught gross anatomy in medical school to the third year, to the first years when I was a third year. That stuff
Oh,
stuck
okay.
pretty well.
Yeah, yeah, it sticks, but like t- I've been thwopped on my head a few times, so some things don't always click right away. But yes, thank you. I remembered the hole. I remember the name of the hole.
That's you got it.
The pokey pokey. Um, so anyway, that happened, and of course, I had patient care injuries. It's just, I mean, if you look at some of my imaging, it's really interesting now. My providers, every time I have something done, because I have so many X-rays and MRIs and whatever, and they're like, "Well, that doesn't look like a 40-year-old woman should look." If they've never met me before. And
Right.
I go, yeah. I was like, you should see the other stuff. And then it's almost like you're playing Where's Waldo? Like, where's the healed fracture? Where's the,
Oh,
if you look at my foot, I've broken my foot 4 times now. Um,
wow.
yes, 4. And so when I got it x-rayed the last time, there was so much edema and swelling that you just couldn't see a lot of what you needed to see. It was covering it up, but he's like, "Oh, there's some buildup." And I go, "Oh yeah, that was in 2011. I had that one," and I'm pointing out the different healed stuff. Again,
And
it's
people think
like you're
that
saying, "Where's
fractures
Waldo?
heal
Where's
and the
Waldo?"
pain, they think that fractures heal and the pain goes away, but realistically, fractures heal, the pain goes away, and then it comes back. You know what I
Yes,
mean? Sometimes it never goes away, and sometimes it comes back. To think that because a fracture is healed that it's not going to hurt is a bad. Any old person will tell you. I broke my left ankle when I was 19. It didn't hurt me till I was 40 or 45, and
right.
then it started aching. I got arthritis and all this. That's how life
Yeah.
goes. And there's a huge disconnect between just the practicalities of human life and the kind of the
And maintaining
criteria
their
that they
quality of
set
life.
up. Yeah,
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 at the same time, it's the realities of life, and how do we maintain someone's quality of life when they're facing any condition that causes them a lot of pain without, again, without causing the least amount of harm as possible, or the risk of harm
right,
as
right.
possible. And that's the balancing act that we are all
Where do
stuck
you think
with.
this is headed? I personally believe that they will let people suffer until they have some very expensive alternative for opiates that works marginally well, and then that's
Oh,
just
they
what
do.
be. That's
There
just
are expensive treatments. My most recent diagnosis is complex regional pain syndrome. I had an injury. I told you about the one to my shoulder, and then the one to my foot in the last couple of months. And it does appear that I have both the chronic, and then I had an acute kind of flare of it. And there is an IV infusion therapy they canceled the clinical trials in the US. So it's not available, and it's extremely expensive. And so you look on these websites over in Italy of patients that are getting this treatment and doing so well with it, but they're all rich white people.
right.
And it's like, what about the rest of us? So
That's
unless
the
I can find
problem.
a physician that will prescribe it off label and monitor the infusion, it's just not going to be realistic for me. Um, but what ended up happening, I worked as a medical case manager. I started out in addiction, and then I actually transitioned into home care and community-based services. So I watched patients go through. I did long-term care management, and eventually I was a supervisor. And then I kind of worked my way up. I was operations director for a 16 county Medicare certified agency. So we had Medicare stuff. We had a VA contract. Oh, you froze a little bit there, hon. Are you still there? Okay.
Oh, no, I, I was listening intently.
Oh, okay. We had a VA contract. We took all insurances. We dealt with Medicaid. So I learned a lot about, it was a very educational position. I learned a lot about the politics of healthcare, and more important, how to get paid. And I have decided that the scariest word to any doctor, one word, Medicare.
Yeah, it's they keep cutting reimbursement. They keep making the coding more difficult. They took away in 2012. They took away the requirement that you have to knowingly commit fraud. Now you can unknowingly commit fraud. They've made it a minefield so that physicians specifically are at every day they practice, they're at risk of losing their liberty. And if they are compassionate and actually trying to help people not suffer. And of course, the greatest calling of any physician is to ease the suffering of those who can't be cured. I mean, that's there's no greater calling, but that is now uh, considered, you might run our stats up, so you got to let them all suffer. Um,
Right.
we don't have an alternative to opiates right now. There is not one. And for many, many patients, that's the only thing that makes their life tolerable. And the
Mhm.
basic response has been, then let them die. That's what we're seeing. The DEA, I mean, we
And
know patients are committing suicide over it. The DEA is saying, well, that's not our fault.
mhm. And the trend that I'm seeing recently, I transitioned into EMS work. I had always had an interest in emergency medicine, and I worked with a nurse years before that that said, "You're going to end up in the ER. I know you. You're going to end up in the ER." She was an EMT prior to going to nursing school, and she's like, "You're one of us," and she was right. And so there was a rural healthcare initiative that allowed people to take EMT class, and you don't really see people born to privilege going into paramedicine.
Right.
You don't really see that. We all have some kind of story. I had a professor that called herself an accidental paramedic. I had another one that was like, I just did it to see what it was like, and I got hooked. And my friend that made me come to class with her dropped out, and I kept going. Um, and unless you're like a legacy, if you're born into an EMS family, kind of like military families, right?
Right.
But for the most part, most of us kind of stumble into it, and we just kind of we realized that was kind of our calling, and that's what happened with me. And that is a very hard job on your body. And
Sure.
what
Sure.
really,
Everybody gets injury. Nurses gets injuries, they get injuries, but
yes,
paramedics
doctors
are
do
in an
too.
uncontrolled environment,
Yes,
and
and that's the thing,
you're going to
it's
get
like
hurt.
until you have hauled a 600-pound patient out of a hoarder trailer with a tarp and a couple of firefighters, who then codes when he falls backwards, and I'm like,
Oh my goodness.
how you
Oh,
doing? You okay? All right. Nice guy though. Um, until you've done that, don't tell me you understand. And
yeah.
I can remember going down, lifting a patient even once. I remember I felt my meniscus tear in my left knee. I went down and it was like rip, and everyone saw my face change. And I finished the lift. I took care of the patient. I took care of the call. The cop came, and the cop is helping push the patient into the hospital because I can't do it. And I'm hobbling along with my tough book. And I'm still like, I'm fine, because I don't want to deal with work comp again because it sucks and I don't want to deal with it. And then finally, I was walking my dog a couple days later, and I'm like, I'm really not okay. I think I need to go to PT or something. I need to see ortho. But yeah, like I've just had constant injuries to my body. And what really kind of gets to me sometimes is I feel largely abandoned, because I feel like I served the public faithfully for a long time in a variety of roles, but this is service related. Would you treat a veteran this way? And that's what they did. They came for the veterans too. The VA went opioid free, or is opioid
Oh
free.
yeah,
Good.
I'm a veteran. I'm terrified of getting any
Yes,
type
thank you for your
of
service, by the way.
pain because they're just, thank you. I served in the Marines first, and
Okay.
then the Air Force, and I sincerely hope I never need VA treatment or get bone cancer and have to go to the VA, because they've decided you're just going to suffer. We're going to be, to avoid criticism, we're just not going to prescribe any opiates, and
Yep.
it is terrifying. And a huge number of veterans have taken themselves out of the equation.
Yes.
But I'm
And
going.
in my family, I have I've dealt with that too. But what? Oh, I'm sorry. Do you have to run? I was going to talk about like the ketamine thing and the other, but
I am going to have to run. But tell me about the ketamine. Tell me about ketamine.
so what's eventually happening, and where I see things trending, is we are sending patients to one of two options. We're pushing patients towards cannabis medicine, and
Mm-hmm.
cannabis medicine is something that I had the opportunity to go to a conference with. There's a company in Minnesota called Green Goods, or Vero Healthcare, and there was a lot of clinicians there. I took the CME track, and I was able to visit their grow facility, which is, if you want to smell what heaven smells like, go into a medical grow facility. It smells amazing. I never knew pot could smell good. Holy smokes. And what I ended up doing, because largely for most of my life I haven't been on opioids, I I used other methods. I've literally tried and true. I've done it all, and so I started using cannabis medicine first before I had to go back to opioids until it wasn't avoidable. It just became not avoidable anymore. But what ended up
Right.
happening is they took opioids off of our trucks. So starting in 2016 with those guidelines, we started seeing them put ketamine on the trucks. And that was something that I didn't have a lot of experience with. because I wasn't in that environment where they would use it. And they tried to tell us that it wasn't addictive. And you're talking to
Yeah.
somebody who in college, I was roofied with ketamine and date raped.
Oh
And so
no.
I raised my hand and I looked at medical director that said this. And I said, so you're telling me Special K isn't addictive? And he's like, well, it's less addictive.
That's a better description.
Thank you.
It's habit forming. Anything that makes you feel good or feel better can be habit forming. I think
Yes.
he's probably meaning traditionally addictive, as in a dopamine surge to the nucleus accumbens, and that's accurate.
Oh, well, and what's happening is they're actually, there's only one service in Minnesota that I'm aware of that carries morphine anymore. They actually carry Dilaudid. Um,
Wow. Oh, they're loaded.
and
Okay.
so it's
Okay.
fentanyl. Fentanyl is what we carry, which is, it's a great option for pre-hospital because the half-life is between 7 and 14 minutes. And any respiratory depression that may occur, if it does occur, is going to be very brief. So you're not going to have to be tubing patients in the field,
Right.
is risky in itself. And we try to avoid RSI if we have to. So we ended up going to, you kind of saw that trend. The problem is that it's now to the point where if a patient has a severe injury, we don't have enough medication on an ambulance to be able to keep that patient, frankly, stable. Because we have patients that you've seen, I know, and I've seen that we've actually had to RSI because that's the only way to relieve their suffering.
Absolutely. Absolutely.
Absolutely. And so we just don't have that. And the doctors that wrote those guidelines are metro area doctors that are used to having medics that are within 10 to 15 minutes of a hospital. And they don't understand what it's like in greater Minnesota because I've worked in the metro and I've worked out state. And so they don't understand that you can go 2.5 hours to a call. Helicopters can't get everywhere. You
Right.
can
Right.
get some
Right.
sirens for a couple hours going to, and you can have that patient under your care for hours. And so we used to carry a lot more in greater Minnesota, and now there's more and more increasing restrictions, unfortunately.
Yeah.
And ketamine can be an option, but if you send a patient to the K-hole, that's going to contribute to their medical trauma, and they're going to be less likely to seek care in the future. So
Ketamine has
um,
a side effect of causing people to have kind of nightmares, to have
yes,
hallucinations and delusions.
hallucinations. We call it the
So,
K-hole.
if you're going to put someone out, ketamine works well. And in low doses, it doesn't have that
Yes,
effect in very low doses.
absolutely.
But if
It
you're
can be
trying
a
to
good
use
tool
it,
in the wheelhouse.
yes, if you're trying to use
Yeah.
it as a full anesthetic, you better give them some Versed. If you're trying to use it as an
Yes.
analgesic, you better stay very low dose, or they're going almost to become psychotic. They'll have delusions and get scared, and they'll get combative.
And
And
then you risk injury to the patient, injury to the crew. And
absolutely.
we certainly don't, I mean, we get assaulted enough on the job. We don't want to increase that. And I've seen it go both ways with patients. And so typically that was something that, and they're using it as a first line treatment for behavioral patients. And we had the B52 for years. It did what it needed to do.
Right.
And I personally steered away from ketamine. They attempted a pre-hospital study at a Hennepin County Medical Center a few years ago. It did not go well.
Now, the
Um,
B-52 you're talking about, for those who aren't
but for
very,
ketamine,
yeah, yeah.
they did a ketamine
It's
study.
five of Haldol and two of Ativan, right?
So the
B-52.
way we do it is 5 of Haldol, um, and it's 25 of Benadryl, and then we used 2 of Versed because I know
Reverse it.
in the hospital they use
That would
Ativan,
do it.
carry
Yeah,
Ativan on the truck, so we
yeah,
use 2 of Versed.
gotcha.
So B52,
We
Benadryl.
had the B-52 for the ER, but it was a five of Haldol and two of lorazepam
Yep.
or Ativan. So
Yep,
yeah,
and it works
yeah,
well without the risk of sending the patient into, again, that, that psychedelic psychosis state that you were talking about, which on the streets, they call it hitting the K-hole.
yeah.
But we didn't have that happening. And so I'm not sure where medicine is heading. I do believe, I have hope. I will end our conversation because I know you have to run on this, is that I do have hope that we are heading in a different direction. It's gotten to the point, when I was younger, I used to get gaslit a lot. They would say, oh, it's in your head, or I think you're dealing with depression. If you have depression, it can somaticize to other parts of your body, which is a
Right.
misuse of 2014 research, as you know. Um, and now it's gotten to the point where my pain is actually known and acknowledged by everyone, down to my insurance company, because my
Good.
record speaks for itself. So I actually do get compassion from providers, and they apologize. I'm sorry, I can't treat you. Because
Well,
even with
I'd rather have
intractable,
someone say, I know you're in pain, but I can't treat
yes,
you, than to say it's all in your head and I still can't treat you and it's your fault.
right, right. And I've had like providers that have known me as a provider for years. They know me. And, you know, I had one of them, I had to go to the ER to get a migraine cocktail. And I heard the tones drop. I accidentally said the Q word. Oops. I was tired. And there was an MCI that happened. It was a car crash that happened. I heard it because I was listening to the desk and I heard the tones drop. And so the provider comes in and I go, I'm sorry, that might have been my fault. I went like that. I didn't make it happen. And he's like, he goes, oh, and he's putting on his yellow gown, you know, and he's like, I just wanted to run in and make sure you're doing okay. The nurse is coming in and et cetera, et cetera. And he was looking at me because I looked at him and I was like, you remember me, right? Because he was the doc that was on the
Uh,
day I had to climb into a ravine and get a 10-year-old out from under a boulder. And that kid
oh,
just graduated high school. So
wow.
I was like, remember that call? That was me. And look at what's happening to me. And
Uh,
he's like, and so he was putting on his yellow gown and he gave me a little half hug and he goes, it was good to see you. I'm so sorry this is happening. Like, I mean, and I was like, that was probably the best thing that I could have heard from anyone.
yeah, it
Even
matters.
though,
It matters. It was a
yes,
paradigm that if as a doctor, if I don't know what's wrong with you, it's automatically your fault. It cannot be that I have failed to diagnose something or that science hasn't elucidated what, for the longest time, fibromyalgia was in everybody's brains, and then it turned out to be about 30 different things, including
yep,
neuralgias and
yes,
Lyme disease, other autoimmune conditions,
yes.
and
Myofascial pain
whatnot.
syndrome.
Well, maybe things will head in a better direction. I appreciate your time and your
I appreciate
willingness to
yours.
give us your perspective. Thank you
Hmm.
so much.
I wish you the best in everything going forward. And again, thank you for your contact information and we'll make sure to stay in touch. Okay.
Thank you.
Keep your
Thank
head up.
I will. I'll
All
stay
right. You'll
strong.
be in my prayers.
Things will get better at some point. I
They
appreciate it.
will. They will. Absolutely. All right. You take care.
You too. Bye bye.
All right. Bye.